So we proceed to the next presentation. Dr. Vidalakis, please.
Vidalakis.
Vidalakis. Okay.
Good evening.
Good evening.
I would like to thank also Mavrogeni and congratulate her for the super seminar. Let's start with the cases. The first case, here we have a 54 years old male with ischemic cardiomyopathy and a prior anterior STEMI 2016 with PCI at LAD. The echocardiography now demonstrates an apical aneurysm with a left ventricular ejection fraction of 27% and global hypokinesia with akinesia and dyskinesia of the apical segments. Here is the LG images, and as you see, there is a scar from the medium to apical intravesicular septum, the apex, and also the anterior wall. The apex again, and the inferior wall. This is a transmural scar. So the question here is there any viable myocardium? Actually, if we see the bullseye of viability, you can say that all these segments with the red color are not viable because they have almost transmural scar. So there is no point of revascularize them and revive them. And if we calculate the bullseye of viability, we can say that the viable and normal myocardium is about 47%, and we need more than 70% to talk about viability, and the viable myocardium is only 17%. So this patient has no viable myocardium. There is no point to open the vessel. The second case is a 71 years old male with ischemic cardiomyopathy and heart failure symptoms. The coronary angiography demonstrates a total occlusion of LAD, and the question here is also the viability. This is a cine image of the four-chamber view, and as you see, the left ventricle is dilated with hypokinetic segments and low ejection fraction. Here also is a short axis at the mid of the left ventricle. You see the hypokinesia. And this is the late gadolinium enhancement images. And as you see, there is a scar in almost the anterior and lateral wall and the apical septum. And this scar is less than 50% transmural. So we can say that these segments, they have a scar which is less than 50% of the wall thickness, and this makes these segments viable. Also, here is a LG image of the long axis view. You can also see the anterior scar. As you see, the scar is subendocardial. It doesn't extend transmurally. Also, the four-chamber view, you can see the scar at the lateral wall and the apical intravesicular septum. All the scars, they have less than 50% transmurality. And this is the three-chamber view, as we used to say. So this patient has a lot of viable myocardium, and if we check the viability bullseye, we can say that the viable and normal myocardium, the pink segments and the green segments, are more than 76%. So we can say that if this patient go to the revascularization, we expect for the left ventricular ejection fraction to improve. Let's move to the third case. Here we have a 65 years old male. He's a smoker, but he has no primary history of coronary artery disease. The last few months, he developed exercise angina, and they sent to our department for stress perfusion cardiac MRI. This is this video represents the stress perfusion, first pass perfusion. This is the short axis basal basal short axis, mid short axis, and apical short axis. Let me play this. As you can see, the gadolinium gets first to the right ventricle, then goes to the left ventricle, and then we can see how beautifully it goes to the myocardium. And here, if I stop about here you can see that the gadolinium doesn't go to this segment, which is the mid interventricular septum and apical interventricular septum, the mid anterior and apical anterior wall. So we have a perfusion defect in these particular segments. Here you can see with the green arrows the areas that they don't have good perfusion. And as you see in the bottom line of the images, the late gadolinium enhancement at the same segments that they demonstrate low perfusion, there is no scar. So we can say that this patient has ischemia at the mid and apical, anterior and septal segments of the left ventricle. He went to the cath lab, and as you can see, there is about 90% of occlusion of the LAD. Just over here. And this is after the stent implantation. Let's go to the next case now. Here we have we perform a cardiac MRI just after acute STEMI, and we can assess if the patient the patient has myocardial damage who has only scar or has microvascular obstruction or intramyocardial hemorrhage. Let's see. This is the T2 weighted imaging, and you can see that this is the area of the damage has edema. It's bright white. It has high signal intensity. So we can say that this area represents a fresh damage. But at the core of the scar, the core of the damage, it has low signal intensity. It's dark. This means that this patient has intramyocardial hemorrhage. On the LG images, we can see the scar, the damage area, because it's very early to say scar. It's better to say damage area. And on the core of the damage area, we can see, again, a dark dot, a dark area, which represents microvascular obstruction. The same findings we have in the long image in the four-chamber view. This is the edema and the intramyocardial hemorrhage inside the edema, and this is the LG image of the damage area, and inside at the in the core of the area we can see low signal intensity because of the microvascular obstruction. So this patient has everything. He has a scar with microvascular obstruction and intramyocardial hemorrhage. This is not a good prognostic for this patient. Now let's go to the fifth case. Here we have a male of 60 years old. He's a smoker, and he has hyperlipidemia. On the transthoracic echo and transesophageal echo, he has a mass attached to the right coronary cap of the aortic valve. And they sent to us to delineate what kind of mass is this on the right coronary cap of the aortic valve. Here is the mass, as you see, with the yellow arrow. And this is the balanced SSFP scene of the aortic valve. And as you see, this mass is moving with the cusps. And this is the tissue characterization of this small mass. As you see on the balanced SSFP, it has a low signal intensity. On the T2 weighted image, it has a high signal intensity. On the T2-1 image, weighted image, it has high signal intensity, which doesn't suppress with the fat suppression. So it's not a lipoma. On the perfusion, it doesn't uptake like the other myocardium. And as you see here on the late gadolinium enhancement, it has a lot of uptake. This means that this mass has a lot of fibrous tissue. So this is a fibroelastoma. The sixth case, here we have a 52 years old male, and on transthoracic echo and transesophageal echo, they see a well-demarcated mass attached to the posterior wall of the right atrium. This is a cine image of about 4-chamber view, and as you see, this is the mass. It has high signal intensity on the balance SSFP cine images. Here is T1 weighted image, and as you see, it is bright white like the fat. And when we apply fat suppression, the mass suppressed, like the fat. The same with the T2 weighted image. Bright in the T2 weighted image and suppressed with the fat suppression. We perform also T1 mapping on the mass, and as you see, the number of the T1 mapping of the mass is almost the same as the pericardial and epicardial fat. This is a perfusion of the mass that we can say that it hasn't got a lot of vascularization. And this is the LG image, and because the fat has a lot of fat tissue, it's a white bright. So what is this? It's a lipoma. The seventh case, it's a 70 years old male with ischemic dilated cardiomyopathy and a left ventricular ejection fraction of less than 20%. He has an inferior inferolateral aneurysm with a thrombus and a mitral regurgitation of +2. Here are the cine balance SSFP image of the cardiac MRI. This is 2-chamber and this is the inferior wall. As you see, this is the aneurysm. And inside the aneurysm, we can say that there is a thrombus. This is the LG image of the short axis view at the point of the aneurysm. And here is the thrombus, as you can see. And also the same slice with cine. So what is this? It looks like an aneurysm, but somebody can say that this is inferior inferolateral pseudoaneurysm with thrombus. And why is that? Because the neck of the aneurysm is smaller than the bottom of the aneurysm. And also, there is no muscular tissue surrounding the thrombus. So, the pseudoaneurysm has smaller neck than the bottom, and also we cannot say that there is any muscular tissue surrounding the aneurysm. Let's move now to another case. Here we have a 60 years old female with a distal LAD total occlusion and apical akinesia with a transmural scar. I use this example in order to show you that we can take late gadolinium enhancement images with low TI, and we can demonstrate very nice the scar extent. This is the cine images of 2-chamber view, 3-chamber view, and 4-chamber view. As you can see, there is an apical aneurysm and dyskinesia. And here is the T1 TI scout. This is the LG images with the TI that makes the myocardium black. As you see, there is a scar here, but it's not so clear that there is a scar. And with low TIs, the dark scar, as we say, we can see how beautifully we can demonstrate the scar on the apical segments. The scar now here is dark, it's black, it's not white like usual. So this is the classic LG image with the high TI time that makes the myocardium dark, and this is the low TI LG image with the low TI that we can see the scar is dark and we can see the whole extent of the scar. Let's move now to the last case. Here we have a 47 years old male admitted to the hospital for symptoms of heart failure. He was diagnosed with non-ischemic DCM and he was referred to our department for further evaluation. He has pericardial agenesis. This is the heart. And as you see, the whole heart moves to the right and to the left and posterior. This is not the normal position of the heart. And what we did, we take a picture of the patient supine, and then we ask the patient to get again inside the scanner and be prone. And we take another picture, and as you see, the heart moves a lot. From this side, when the patient becomes prone, he moves here. So we can say that this patient has no pericardium. And this image reminds me a lot of Dali's picture.
Congratulations, excellent cases. Just two short comments. I think that the CMR is the ideal technique for the cardiac masses to tissue characterization and to see if there is all the anatomical tissue characteristics. And another short comment concerning patients with chronic coronary artery disease. I think the study of viability is very useful. Even after STITCH trial, I think that we have to use in most of the cases the viability study, particularly in cases with complex coronary, complex anatomy of the coronary stenosis, and the cases with chronic kidney disease and some other cases. So I have to answer to one question by Dr. Zacharioglu, and after Dr. Vatterla answer to another question. Dr. Zacharioglu, Evangelia, asked a clinical question in a woman with 30-year-old ejection fraction 50%, diastolic diameter 54 millimeter in echo and normal stress echo. I think bicycle stress echo with feeling of non-specific discomfort could be a candidate for CMR. I think that she is a candidate for CT to see the anatomy of the coronary artery disease, not another study, stress study. So, Dr. Vatterla, could you answer, please?
Yes, I'm here. Yes. No, the answer is that not all the Minoka syndrome have microvascular obstruction. It depends of the mechanism. For example, if there is a disruption of a plaque, then we can have a microvascular dysfunction, then we have a hemorrhage. But if we have a coronary spasm, then we don't have MVO. That's my opinion. Sophie, what's your opinion on that?
I think that this woman has a mildly reduced ejection fraction, if it's 50%. She's a woman, which means she has atypical symptoms. I didn't recommend a stress CMR, but a simple CMR if she has still discomfort, just to see if there is evidence of recent event, whatever it is, myocarditis or myocardial infarction or anything else, just to see if it is something, if acute happened to the myocardium, or if it is concurrent scar, or if it is generally increase the values of mapping without any obvious LG, which means a potential cardiomyopathy, which is should be under evaluation. But in any case, I wouldn't leave a woman with a typical chest discomfort without doing any further examination. Just because in women, we all know that the majority of them have always a typical chest discomfort, and also in men, in 1/3 of them have epigastric pain. And I discovered a lot in my private clinic now. They came to gastroenterologist 2 or 3 times, and when we evaluated by CMR, we discovered a lesion which provoked a sort of myocardial infarction, which was totally unnoticed. No Q wave, no enzymes, nothing, because it happened maybe 15 days ago, and the patient did not appreciate it. Everybody accused the gastroenteric system for this epigastric discomfort. So it's rather tricky, and we have to be very careful. Usually we miss a lot of myocardial infarctions in women just because we don't consider them as a reason of chest discomfort. Sorry, it's to cardiologists, but it happens.
We don't evaluate their symptoms, the woman's symptoms, I think.
Because we don't really know, we don't have clear in our mind what are the symptoms of coronary artery disease in women. Just because coronary artery disease in women is very complicated. It's not just obstruction. And if you see the pathophysiology of 2 sexes, you will see that inflammation is the main reason of chest discomfort in women, while ischemia is in men. I mean, this is the reason that women have more in most that in many autoimmune diseases where there is a problem with the inflammatory response are women and not men, because women react with inflammation. It's a different way to react in an external factor. In contrast, men react with ischemia, and this is the reason they are more common. It is more common to find ischemic lesions in them. And on the other side, women have, you know, very subtle, very small coronary arteries, many hormonal influence, balanced hormonal changes or unbalanced hormonal changes. So all these factors make the clinical presentation very complicated. So CMR is an objective modality. It's good to use it when we have even a small suspicion, because if a patient has an MI and we leave it untreated, you know the consequences. I don't have to mention that.
Will you perform, Sophie, a CMR in a young girl of 20-year-old with these features?
I performed some women with polycystic ovaries, which they are high risk for cardiac events, and I found some evidence of ischemia in some of them, but I didn't scan many patients at the moment, so I don't really know. I'm not ready to give you final thoughts, but I discovered ischemia, which means that hormone imbalance, which is common in this disease, may play a role.
Maybe.
Yeah. But in any case, they have high incidence of coronary disease, these women.
Okay.
We proceed to the last presentation, Sophie.
Before we leave Dr. Vidalakis, I like to emphasize that a black area within the scar may be MVO, microvascular obstruction, or even hemorrhage, and we need to start to differentiate intramyocardial obstruction from intramyocardial hemorrhage. T2 star is very low if it is hemorrhage. Just this. Yes, otherwise, it was excellent talk.
Yes, that's why I put the T2 weighted image, but T2 star is more specific for
detection of iron. It is the specific sequence. And it helps because black area could mean 2 different things, either hemorrhage or MVO. So we have to discriminate. Thank you so much anyway.
Thank you very much.
Let's go.